technology really outpaces the evidence. So we are faced with lots of new technology, marketing terms, and that kind of thing without necessarily feeling like we have a lot of evidence. You also need to be, I believe as a clinician, a critical consumer of the evidence space. So we'll spend a little bit of time on that, of hopefully how we can be critical consumers, again, and in a timely manner, as we're looking at whether we're looking at actual published evidence or if we're looking at marketing types material. And with all that, then, hopefully we become this bridge. And I happen to show you here a picture of the Fort Pitt Bridge, which is the bridge that leads into the city of Pittsburgh, which is where I'm from, which is really just a little, it's actually quite a little city. And it makes me think a little bit of Liverpool in that coming to Liverpool, I think from the US you have a feeling that it's not that pretty a city, and yet it's really a lovely city. And I think in the US people feel the same way about Pittsburgh. And so it's always a nice surprise when people come and see that Pittsburgh is actually quite a nice city as well. So I give you this quote just to start out, and it's the thought that just because we've all been doing something doesn't really mean it's the right thing to do. And that's part of this push, really, towards evidence-based practice, to make us really examine what we've been doing, even if it's something we've all been doing for a long time, to go kind of take a step back and say, what is really supporting us doing this? So when you look at the evidence-based literature, what it's really done is demoted the expert to the lowest level of evidence. So we've gotten away from kind of that sage on the stage type person who just comes and lectures and tells us how they do things, and then we all go home and do it the same way. We really expect now for an expert on the stage to be citing the evidence, to be giving backup for what they're saying, for why they're telling us maybe to do certain things in the clinic. So I want to take you through a few things today that I think are important to this topic. And first we'll go through a little bit of terminology, because I do think it's important that we all speak the same language when we're trying to cover this topic. So we'll go through a few terms that may be familiar, and just to make sure we're all on the same page with that. And then I think we'll go through some things that I think we need to know. The first will be a little bit about systematic reviews, which are something that's very, very helpful to both the clinician and the researcher. So we'll talk about that a little bit. I'm going to go through a protocol of how to answer individual clinical questions, which really is the foundation of evidence-based practice, when the clinician takes that little bit of time to answer specific questions about your own patients. We'll go through a little bit about being critical consumers of research, which really goes hand in hand with that topic. And then I'm going to take just a minute to think about marketing materials, because again, especially in the area of amplification, this becomes really critical to us as audiologists to be able to make some decisions before we have very strong evidence in the literature.
The British Academy, and we're started yesterday. In the next few days we're going to be formulating a strategy to deal with this. I just wonder, could you comment on, because your comment seems in line with our concerns and difficulties.
Sure. It's a good question, and it makes me think. I did some work with the government in New Zealand that also has national health care. So when you think of protocols, there are some very positive places, I think, for protocols. I would suggest them in things related to like measurement techniques. So again, going back to real ear measurements, or having protocols about how one tests babies, how one tests people, how one tests audibility. So I think there's some real positive in that type of protocol, something we're missing in the US, which is a problem for us. So we don't have a standard of care in that sense. But in terms of treatment, that's different. So in working with the New Zealand government, one thing we were looking at is using this evidence-based methodology. Could we come up with kind of a minimal set of requirements for amplification? So you can look at the evidence and say, okay, how many channels minimally would one need? What kind of microphones? And you can come up with a recipe like that, but then it departs for every individual patient. So you'd say, okay, we would never give anyone less than this, because we've all agreed by the evidence that this is the minimal requirement. And then the clinician's job is to look at their patient and say, okay, but clearly I need all the minimum requirements, but I need these extra requirements for these reasons. And it would be reasonable in a national healthcare system, I would think, to justify that, just, you know, briefly, to be able to say, okay, I've gone from the minimal to this higher level, and this is why, because there are these certain communication situations, etc. So I don't think you can have a recipe for the technology, for the treatment. I do, however, think protocols are very useful for testing kinds of things.
Okay, thank you very much.